Tēnā koutou katoa. Only 17 and a half weeks left until Christmas, but tonight Christmas comes early with Associate Professor Tony O'Brien from the University of Waikato and his partner in crime tonight, Johnnie Potiki from Southern DHB. Tony entered nursing in 1974 and completed a psychiatric qualification at Auckland Hospital Board School of Nursing. His clinical background includes adolescent and adult inpatient care. His interests include standards of practice and ethical issues in mental health care. Recently, Johnnie tells me he actually got a Queen's Service Medal too. Johnnie is a consumer advisor for mental health services. In this role, he provides direction, leadership, and advice to support improvements in service development and delivery. Together, they will be treating us to a webinar titled Advanced Directives in Mental Health Care in New Zealand. I'm looking forward to hearing what they have to share with us.
Thank you. Thank you very much, Catherine, and welcome to you all. Tēnā koutou katoa, ko Johnnie Potiki aho. So we're going to talk tonight about our MAPS research. And the MAPS research it started off with advanced directives, and it started back in 2015 when there was very few advanced directives in the Southern DHB. I think there was about 15 altogether, and previous consumer advisors had tried to increase the number of advanced directives without much success. So we did a skills for change in the Southern DHB, and in the skills for change, we decided that we'd like to increase the number of advanced directives. So skills for change is a quality initiative. Increase the number of advanced directives. We wanted to be able to educate people about advanced directives, so that's staff and consumers. And we wanted to create a new document, because the existing document we had was 3 or 4 pages long. And we also wanted to change the guidelines that we used in the Southern DHB as well. So during the skills for change, Tony happened to be down from Auckland University, and he was doing work with postgraduate nurses. And I knew he'd done a piece of research with Katie Tom. So I spoke to Tony asked him if we could speak about his research, and he came in and we spoke about the research, and he suggested we might try and do a piece of research here in the Southern DHB. And so we started on this path where we created a team, and the original team was myself, Heather Casey, the nursing director at Southern DHB, was Tony from Auckland University at the time, and also Auckland DHB, and Katie Tom from Auckland. And we also had a couple of local experts down here, Professor Paul Glue, a psychiatrist in the School of Medicine and at the Southern DHB, and Professor John Dawson is a kind of a legal expert, and he's also at the Otago University. And we try to gather some money and to do this research, and we did get some money from the Hume Foundation, and we were able to employ a research fellow, Jessie Leonard Glue, to sort of be the glue for our team, actually. And so at the stage we are now, we've added 2 more people. We've added Daniel Tawaroa, and we've also added Matthew Kiori, because we're looking at doing a Maori-centred piece of MAPS work now. So what I'm going to do now is I'm going to show you a short video, about 2 minutes long, just to give a rough idea of the kind of work that we do.
Johnnie, can I just do a brief intro first?
Oh, absolutely, Tony.
Yeah. Kia ora, everybody. So as Johnnie says, my name's Tony O'Brien. I'm with University of Waikato these days. And yeah, and very exciting to be presenting this tonight, and great to see all the messages coming from various parts of the country, South and North Island, and everybody kind of interested in what we're going to be talking about. So yeah, just to kind of reinforce what Johnnie said, this was an initiative of Southern DHB. Johnnie and I had a discussion about it, I think it might be 5 years ago now, Johnnie, and it's kind of grown from there. So I'm very pleased to be here to share the research with you. Looking forward to your questions. I'll hand over to Johnnie.
Okay, so I'll show the video now.
Tēnā koutou katoa, ko Johnnie Potiki aho. I'm the Consumer Advisor for the Southern DHB Mental Health, Addictions and Intellectual Disability Department in Otago. This project that I'll be talking to you about today, the Mental Health Advanced Preference, is something that I've been very passionate about and believe in quite a lot. The Mental Health Advanced Preference is a way that a person can get their choices across when they may not be in the best position to be able to do that. The best time to write the map would be when you're in the community and things are going really well, and this is a good way to get across the kind of care you want in the future if they became unwell. So it could be about the kind of medication that you're receiving, or it could be about the home and something in the home that needs to be looked after while you're in hospital. So you have a mental health crisis, your map will be flagged and it will come up as an alert. The clinician will open the alert, look through your mental health advanced preference, and then they will have a conversation about what's in the mental health advanced preference. And the clinician has that tool in front of them, and so they know that these are the things they want, and then it's just a matter of weighing up whether those things can be provided to help get moving to personal recovery. We do have the Otago Mental Support Trust who have their support, and they have great ability to be able to support the person to fill out a map. As a Māori, you have absolute right to cultural support. Writing your map, you can have access to a kaumātua, you can have access to the Māori mental health teams, and hopefully the peer support services could provide a cultural support worker to help you with that as well. There are other people that can be involved in helping to create the map. It could be your family, and it could also be with your caseworker or doctor. If your preferences change, a good thing to do would be refill the map out with your clinician or your peer support worker and relodge it on the system. So the map will be on the Southern District Health Board website, and you'll be able to do it online. There will also be hard copies around each area of the service with an information sheet about the map and a road map going along with that, explaining certain things that you can have in your mental health advanced preference.
So I would like to hand over to Tony now to discuss the topic.
So yes, we're going to go through some background for this advanced directive research. We're going to talk about some studies that we've done in support of developing advanced directives for use in Southern DHB. We've published about 4 or 5 papers so far. I think there's a list of those at the end of this. If there's not, we can certainly send you those. And we're going to talk about how we now want this initiative to go from Southern DHB wider throughout New Zealand, and what some of our next steps are to do that, particularly in relation to the Mental Health Act, and looking at what sort of content and process Māori would like for maps to work for them. So that's so I'll hand over to you, Johnny, for the...
Yep, sure. So what is an advanced directive? So as you can see what's on the screen, and what I wanted to really just share with you was that in simple terms, an advanced directive is the giving and refusing of consent to treatment in the future. And it's a statement to others, usually in writing, setting treatment priorities if the person is unwell or is unable to consent to treatment. And so I'll just move on to the next slide. And would you like to talk to this, Tony?
Within New Zealand legislation and rights processes, every consumer has a right to use an advanced directive in accordance with the common law. So what that means is that you don't need a project, an initiative, a clinician, somebody to present you with a standard document to say, here you are, you can write your advanced directive. You can just do it. You can just get a piece of paper and write it out. So you have that right within the common law. Now, what we know in the mental health services and in health services generally is that it's very helpful if these things are standardised. So that's what we've been doing with Southern DHB, is to have a standardised way of doing this. We just further background in relation to New Zealand, the 2012 Mental Health Commission, since disestablished and now re-established as a Mental Health and Wellness Commission, called for advanced directives to help service users express preferences. And that's something that's very important around advanced directives. It's about having a way that consumers can express the preferences that they have in relation to how their care is provided, and we'll talk specifically about that later. In 2017, a Ministry of Health reference group on human rights and mental health legislation recommended advanced directives. So we've seen over the course of this project movement from the kind of recognition in the health and disability rights to the Ministry of Health saying, actually, we really want this to be part of the mental health landscape. And we'll have some more to say about that later on. And as Johnnie said before, at the time we started, there were 15 advanced directives in the Southern DHB, and most of those were EPOA activation notices, so they weren't advanced directives like we're going to be talking about tonight. So that's our background. We can probably go to the next slide, Johnnie.
Yeah, so the impetus for this project, so we're of the opinion that advanced care planning or advanced directives can increase consumers' experiences participating in decisions around their mental health care. And advanced directives are an identified evidence-based intervention to support the person's choices in their journey to well-being. So if we can promote people's choices within our services, we're moving towards them participating in decisions and supported decision-making. And so that's got to be a good thing, I think. And as Tony mentioned, the lack of advanced directives. In the 10 years prior to this initiative, there were that 20-odd advanced directives. And some of those were just the advanced directive alert, and majorities just signalled an enduring power of attorney. So we have two very influential supporters for advanced directives and supported decision-making. They're Dr. Crawshaw, Director of Mental Health, and Kevin Allen, the Health and Disability Commissioner. And they're both following our MAPS research, and they're both very passionate about supported decision-making. And part of the reasons for that is around restrictive practice and around the Mental Health Act and our obligations under the United Nations Code of Rights for People with Disabilities, which recommends that governments take immediate steps to revise laws and replace substituted decision-making with supported decision-making. And this should provide a wide range of measures which respect the person's autonomy, will and preferences, and is in full conformity with Article 12 of the Convention. So we do have entrenched attitudes in both clinicians and consumers around advanced directives that they wouldn't be used appropriately, and some consumers believe that if they had an advanced directive, it wouldn't be followed, and some clinicians believe that if they that the person would, when they wrote the advanced directive, it would be an advanced directive that was going to be unmanageable or unable to be achieved. And so we've kind of started this collaborative project, and the research has shown that mainly those things are not strictly true, but we'll find that out once we get on to be able to stage 2 of the research, where we can actually follow how that's been working for people. So what we have here is a roadmap which was designed by Katie's husband, and the roadmap kind of, all of the things in the roadmap which you may not be able to see, but if you go on the Southern DHB website, you can get a copy of the roadmap, and that's you'll be able to see them clearly. So it's what I'd like to see have happen, what I don't want to have happen, who should be contacted when I'm in a crisis, who I do not wish to have contact when I'm involved in my clear, managing personal affairs, preferences, and other. So all of this came out of the co-design workshops that we did with consumers and whānau, and so there's really every single thing around the roadmap and in the advanced directive tool itself have all been, that's all come from people who use our services pretty much. So, Tony, would you like to talk about MAPS since 2016 and what does our research show?
Sure, yeah. So actually this is quite a big topic in many ways. I'll go through very quickly the studies we've done. So Johnnie mentioned before that prior to this this development with Southern DHB, I'd been involved with Katie Tom, one of our other researchers, in doing a survey, a national survey of clinicians and service users about their perceptions and experience of advanced directives. We weren't using the term MAP at that stage. And we found that there was generally high levels of support for advanced directives amongst clinicians and service users. There were some differences in views, and they were particularly around the areas that you would expect being the most contentious around the use of compulsory treatment, and measures like use of seclusion. So those were where there was a divergence of views. There were differences in views between how confident service users were that clinicians would follow the preferences expressed in an advanced directive, but nevertheless there was very high support for their use. So we took that research and did a similar study in Dunedin and Southland in the Southern DHB, asked pretty much the same questions and got very similar results. One of the things that we found with both of those studies was that the things that people wanted to include in advanced directives were clinically feasible, and that goes against the anxieties that are sometimes expressed about people would ask for things that are unrealistic. We've found both times when we've done these studies that that's not the case, that people ask for reasonable, achievable things. There are some differences, but they're not great. We found generally kind of positive views around consumers' expectations about whether an advanced directive would help in the sense of being engaged in the care they were providing, that they were being provided. So that was our first study, a survey. Then we ran some focus groups and explored further the content of advanced directives, what people would like to see written into their advanced directives. We did another study where we looked at completed advanced directives and what do people actually say, and what kind of preferences do they express. I think we've got one other published study, but it might have been covered by the work that we've covered so far, or it might come up again shortly. So we've been kind of following this program of work since 2015, and I think we could say now that we've re-established that there is a lot of support for advanced directives. The things that people want are reasonable, and there's a high level of consensus between clinicians and consumers about the advantages of advanced directives. So you ready to go, Johnny? Oh yes.
So
okay.
Since 2018-19, we really came to the decision around preferences and not directives through the focus groups, and people wanted things in the advanced directive that were distressing, but they weren't around their healthcare. And I was always of the opinion, and I really liked the word advanced directive, I was always of the opinion that things such as who was going to look after the dog, who was going to get the mail, who was going to check the lights were off in the house, were not health, they had nothing to do with healthcare, and so they couldn't be called an advanced directive. And what we found is that people really cared about those things, and so we've added something into the mental health advanced preference around that specific thing. And it's still, I think in the content analysis, it's still quite a popular area. And so this arriving at the decision for preference is it's a consumer-led process. And one of the really important things that we also learned from the focus groups was that it's important to have a trusted person to facilitate the creation of the map. So it's my tool, but I'd like to fill it out with someone that I trust and can create, and we can have dialogue and discussion around it. So for myself, it would probably be my psychiatrist, because I think it's the person that I believe would be able to do things like, if I was on a medication that I wasn't comfortable with, we could have a discussion about what could be an alternative. For some people, the trusted person is the peer support person. And as we mentioned in the video, it could be whānau, it could be key workers, it could be any person that you trust. And we have all of our documentation on the Southern DHB website. I think it's called Southern Health. And there's a little link that you can click on to get through to all the documentation that we have. So would you like to talk about hindering factors for map completion, please, Tony?
Sure, yeah, okay. So this was one of the other studies that we did actually that I didn't mention before. We looked at what were some of the factors that could help or hinder the completion of advanced directives. And that publication is it's not actually published yet. It's been accepted, but the journal is waiting, I understand, to do a themed issue, and it will be included in that in psychiatric services, hopefully later this year. Resource limitations, that's unsurprising, I guess. They're sometimes a limitation, a hindering factor. Procedural issues. So advanced directives do have their complexities in terms of you know, how do you do them, and what kind of support do you need? What's good wording for an advanced directive? How do you know if an advanced directive is valid if the person had capacity at the time they wrote it out and wasn't unduly influenced by somebody else, a clinician, a family member, or anybody else? So there are those sorts of issues. Access and storage problems. That was something that we discovered, actually. We thought we were doing a fantastic job of thinking all this through. We would design a map, we'd have it written out, it would be available. But what we found was that when it came to writing out a document and having it available through the electronic records, that was by no means straightforward, but we were very fortunate that the IT people at Southern DHB worked quite hard with us to get that system to work, and it now works so that it can be completed online. Then it's an electronic document linked to the clinical file. There's an alert that pops up if the person's file is opened, and the clinician knows that there's a map on the file. Now, like a lot of other alerts with the clinical records, the clinician can then proceed to the next part of their documentation or whatever they're doing, and they don't have to access the map. And we can't put a stage in place to make them do that. But I guess that's where we get to the point of saying part of this is around making the process available, and the rest of the work is around working with clinicians to help them to understand the value of the map for the consumer so that they'll want to do it. We think that the map will be helpful with people's care, so we want them to be able to access it, and having it available electronically has been really big a part of the process for us. But that is another barrier that's noted in the literature. And the other one that I think you might have mentioned already, the differences in views between clinicians and consumers regarding implementation. So that's a barrier to getting this sort of initiative off the ground. We've kind of got over that barrier with the project in Southern DHB. We've got an advanced directive instrument developed, available, and although there will still be differences of opinion between clinicians and consumers, we've got a process in place now. Thanks, Johnny.
And would you like to speak to this as well, Tony?
Okay, so one of our aims with this project is to help to create a shift in culture towards the use of advanced directives and towards care which is more collaborative and encouraging treatment as well as appropriate treatment refusal. So we want people to work with, we want clinicians to work with consumers. We want to establish that kind of collaboration. But we also want consumers to be able to refuse aspects of the care they might be offered and have that refusal respected. So it's a real balancing act to achieve there. And I think it would be fair to say that in the mental health services, we do have that history of being very paternalistic, the way we think about mental health care. So for us as clinicians, there's a big culture change to make in terms of saying, well, here's what we can offer. And then taking seriously if somebody says, well, actually, that's not what I want. So culture change is quite big. I should just say that in my PhD, I studied mental health legislation. And one of the things I found there was that there's been, as you know, lots of changes in mental health legislation internationally over 50 years or so now. And one of the things that's been observed in the literature, and more than once, is that when you get a change like this, thinking about advanced directives, although you might look at legislation as one way of supporting that change, and it is a way of supporting it, what often tends to happen is that once it starts to be talked about, the change begins to happen in advance of the change in legislation or even a change in policy. Now, we mentioned before that the Ministry of Health has talked about making advanced directives part of mental health care, encouraging clinicians to work with them. There's a new guideline which is going to be published any time now to the Mental Health Act, and that's going to have quite a lot of reference to advanced directives in it. And so even although advanced directives are not in our mental health legislation, you can still work with advanced directives as part of somebody's care. You don't have to be directed or compelled to do that. Okay, Johnnie, what's next?
Yep. I just wanted to add that I believe that MAPs support people to remain in control when they're at their most distressed. And a MAP can be used in conjunction with the treatment plan. And MAP offers a chance for a collaborative process while increasing the person's control. So I think that's quite valid. So the rollout of MAPs in the Southern DHB, so we've had our technological hurdles. As Tony mentioned, one of the biggest ones which we got over was with the help of Paul Campion and the IT team. So a MAP can now be filled out electronically and automatically submitted. That's on www.southernhealth.nz, Mental Health Advanced Preference Statement. So if a MAP gets submitted by a person this way, they can be contacted to ensure that it's their MAP. So it's one of the really important things is that it's the person's MAP, not somebody else has filled it out, like their parents on behalf of them. And so Jessie will follow up with the person just to make sure that it's their MAP and it's exactly what they intended to have in the MAP. Otherwise, when it's done in face-to-face, it's witnessed and can come onto the system that way. So one of the most important aspects of this initiative is to ensure that there's an education for both service providers and service users about MAPs and what they are and how they can complete it and why they may be beneficial. And so to facilitate this, our team, we've probably done close to, I think it was 18 presentations, 21 service provider presentations and 5 with professional bodies. And we've done this in various locations throughout Otago and Dunedin and Invercargill, Gore, Alexandra, Oamaru, Wanaka, Clyde. And so we've also presented this information about the MAP project to 5 professional bodies in the form of continuing medical education seminars. We've spoken to the counsellors, psychologists, GPs, mental health professionals and a psychiatry ground round. We've done 2 presentations at the ground round. And we've had most success in creating MAPs when an individual in a service is the champion and they really are promoting it with the people. And we also, our goal is to find more champions within each service. And the other area that's been really successful is at some of the activity centres like Focus Clubhouse and Stepping Stones. And what the managers have done, they've asked people if they would like to do MAPs. And if they've said yes, we've turned up and supported people to do MAPs. And it's been a really collaborative process. And it's been really enjoyable being able to support people to do this. So would you like to talk about the research to date, Tony?
Yeah, sure. Can I divert just for a minute? There was a question that Catherine asked us to answer, Johnnie, and that is, do we know whether other DHBs are actively working on MAPs? And the answer to that question is yes, there are some. Johnnie, do you want to talk about that? I think.
Yeah. So I know. So I've shared this. I've shared all of our work with the Consumer Advisor in Nelson, Marlborough, and they've used quite a lot of our work. They've created their own. They've created their own documents, and they've used a lot of our work, but they've also added a few other things to it as well. And we meet occasionally with other DHBs that are interested to see if we can share things together with each other. Apart from that, I can't really think of any other DHBs that have really had a strong drive.
Which ones did you mention, Johnnie?
Nelson, Marlborough was
one.
But we also have consumer advisors who are champions of advanced directives. So Frank and Whanganui is probably one. So I imagine that peer support services are really promoting advanced directives, I believe, as well. But I've never really done a benchmark or a stock take with the other consumer advisors about who are doing advanced directives.
No, and my experience is that I don't think there's any other DHB that's doing this systematically. There might be individuals that have written advanced directives, but as I was saying before, having a kind of accepted process and supported process within a DHB is really important for this, and it really helps to give them kind of validity and more kind of exposure. There's another question which we'll come back to later, but I'll just mention it now. That is, will advanced directives be included in future mental health legislation? But I'll park that for now. We'll come back to that a bit later. So this is one of our research studies. I don't think I'll talk about this, Johnny, because I think we've already covered that and talked about what that found. The content analysis, though, that's worth talking about. Should I talk about that?
Absolutely.
Yep. So what we did here was we took maps that people had written and we looked at the content of them, and we tabulated all the statements that were made. This was an anonymised study using data extracted from advanced directive instruments. And then we organised all of those statements into groups that kind of fitted together. So these were the 8 areas, the things that you can see there. What I would like to have happen, what I don't want to have happen, who should be contacted, who do I wish to have included in my care, and it's gone again, who don't I want to have included in my care, number 6 I can't read, and then other preferences, other relevant information. I guess the thing that was really striking about that was that there were so many fairly ordinary things that people wanted to communicate that they wanted if they were involved in a mental health crisis. And they were things like, I want somebody to take care of my pets, I want somebody to make sure my house and flat is locked up and the keys are safe. I want to stipulate who I want to be contacted and who I want not to be contacted. And people have very strong ideas about that. There were preferences about wanting to have care at home, and there were some preferences for what kind of inpatient care the person might want if they were to be admitted. Johnny, do you want to add to that?
No, I was sort of typing, Tony, so I was just answering that. I imagine that Taranaki would like, definitely, I imagine, I know the consumer advisor in Taranaki, and I imagine that they really are promoting advanced directives as well. So I don't want to answer that. I had my mind elsewhere. Sorry, Tony.
That's all right. That's all right. Oh, management of personal affairs. So, you know, sometimes people are concerned about they've got bills to pay or appointments or things that they've arranged that they're not going to be able to meet. So they want somebody to look after those things for them. So you can see that these are not necessarily clinical things. They're not about drugs. They're not about coercive treatment. Those things are there. Those things are definitely there. But a lot of the things that people wanted to include in their map were kind of, if you like, peace of mind things. So that was a real good finding from this part of the study, I think. It was that this was not all about the things that are kind of high profile and controversial.
So somebody did put in the chat about seclusion and could they have not to be secluded? And I absolutely agree. And I think that's quite an important thing to put in because we're all trying not to seclude. It's one of the major goals in my role is the goal of zero seclusion. And I think if you do put that you don't want to go into seclusion, I think it's really important that you have other options that are alternatives to that. I'm not sure what they are. It could be perhaps that you would like to be in open intensive care, I think they call it. So always thinking about less restrictive practice. If seclusion is the most restrictive practice, then thinking about other options with much less restrictive practice. And I would be hoping that you might say, you know, if you really feel they have to be secluded, perhaps could you try, would you be able to try me staying in my bedroom or something like that? So just really thinking about other options.
And that, of course, comes in the context of commitments to zero seclusion. So, you know, we know that seclusion has been reduced by huge amounts across the country, and that's continuing. We're not at the point of zero seclusion yet, but hopefully that won't be too far away. Now, that question raised the issue of can an advanced directive be overruled if somebody is under the Mental Health Act? And the simple answer to that question is yes, it can, but what we want to encourage with the advanced directive is the sort of process that's already in place with the Mental Health Act, which is that because the Mental Health Act gives the responsible clinician to direct the care of the patient, including treatment that they don't want to have, although the power is there, we want clinicians, even with people who are under the Mental Health Act, to work with their preferences. The Mental Health Act doesn't oblige the clinician to treat you against your will. The Mental Health Act actually tries to seek consent, and we're kind of supporting that process. So if, for example, there was a question about medication, let's say somebody was very acutely distressed, and the clinicians working with them were having difficulty in helping them manage that distress, and they thought that medication might be helpful or even important, vital even for their treatment. What we would hope to do, hope would happen, is that the clinicians would work with the person around gaining their consent to have the medication that they might initially not want to have. Now, obviously, the bottom line of that is, you know, the clinicians have that right to treat in law, but we don't have to go straight to that right, that legal right to answer that question. Within the spirit of the Advanced Directive, we would want the clinicians to work with the person's preferences, which is kind of not unique to Advanced Directives. It's part of the way we want care to work anyway, by negotiation. So we don't think that's a big stretch from what we're doing currently. And it's important, I think, to realise that if a person's under the Mental Health Act and they have an Advanced Directive, the Advanced Directive is not invalidated by the Mental Health Act. There are just constraints around what the responsible clinician might feel they can work with, but they should acknowledge the preferences, explain why they're not able to be worked with at this particular time, maybe look for alternatives, that kind of thing. So we would get a more kind of collaborative approach to care.
And of course, there are many things in a mental health advanced preference that have got nothing to do with health, so they can actually, there's no reason why they can't be followed. If it's around things to do with what could happen at the home or outside of healthcare, there's no reason at all why they can't be followed, irrespective of whether they're under the Mental Health Act or not.
Yeah. Shall we talk about this? These preferences, Johnny, that
Yep, sure.
were expressed in the Advanced Directives?
I think we just go on to the next slide, Tony.
Okay.
Yep.
Okay.
So as mentioned before, some of the facilitating factors for MAP completion is nursing champions, so specific people that really believe in the Advanced Directive for MAP, and so whenever they are seeing a person, they will do it with them. So an example of one of them, a person that come into the and they didn't have a MAP and they ended up in hospital, and then the champion had done some work with the person, did a MAP, and the MAP was followed, and the person managed to avoid hospital. So you can have really good outcomes if people are passionate about it. It's really important to have a functional and user-friendly IT system, and that's really, it's one of the areas that we probably would have been better if we'd started with that right at the beginning and set up the IT system to begin with, but we didn't really know what was going to happen, so it was pretty hard to set it up in the beginning. So outreach and information for all interested parties. So that's always important that we keep on putting out information. And we've targeted education and training, as I mentioned before, and we've done quite a lot of rollout, and we'll continue to do rollout in areas that that we haven't had an opportunity to do. Originally, the research was specifically in the Otago region, and so we focused it in the Otago region. Now we can actually move it out into the Central Lakes and Southland as well. And yes. And the other thing there, I think they speak for themselves. So we really positively try and address negative attitudes. There's always going to be people who are going to be negative about advanced directives, but I think if we stay positive and really believe in it, that can work. And I actually think that one day I'd really love to see someone who has really negative attitude. Some of the negative attitudes we kind of hear are things like, well, we're already doing that, so why would we want to do that again? And of course, another thing that a lot of people say is, well, that's just doubling up. We already have a treatment plan. So all the things in an advanced directive, we've got them in the treatment plan, but it's not strictly true, because the treatment plan is what the nurses want to, what's important to them. And they may do that in collaboration, but this is completely my tool, and it's the consumer tool. It's got, the clinician can support me with it if they want to, but it's my thing. It's not theirs, and it's not an extra piece of work. And I really do think it assists consumers. So
we've got about 6 or 7 slides to go. Johnny, we're doing okay for time.
okay. I think we'll just, I'd like you to just talk about the Mental Health Act, Tony, and then we can go to questions.
Okay. So there was a question about will advanced directives be included in the new Mental Health Act? Well, of course, we don't know that because there's still the very early stages of consultation about that going on. But we've certainly put our hand up to the ministry to say, well, we think there is some value in this. And we've produced a briefing paper, which we're in the process of developing a website. Once we've got that, the briefing paper will be available. We've circulated it widely. If you've registered for the webinar, you might be able to ask the Mobile Health to make that available. They can send my email address on. You can Google me. I'll send it to you if I get an email from anybody asking for that. We've made it a publicly accessible document. And that is kind of giving advice to the ministry about what we think the place of advanced directives might be in future legislation. So we've looked internationally, and in some jurisdictions in Australia and in Ireland, I believe, advanced directives are written into their legislation. We've looked at Victoria. Their Mental Health Act includes reference to advanced directives. It does include the override clause, if you like, that if the responsible clinician, or whatever the term they use, is authorised psychiatrist, believes the treatment's not appropriate, then they can override the advanced directive. However, if they do that, they've got to inform the patient of the decision and the reasons for the decision, and advise them of their request, advise the patient of their right to request written reasons. So, you know, there's extra rights built in around this, but it still doesn't make the advanced directive, override everything else. So we kind of can learn from that with our own legislation. It's worth saying, I think, that what we want with mental health legislation is actually to use it less. And so we can't look at legislation as being the only vehicle for advanced directives. We want them to be there for everybody who might need some statement of their preferences in the event of a mental health crisis, whether or not that involves use of the Mental Health Act. Obviously, people who have been under the Mental Health Act might have a higher stake in this, because they might be the people who feel that they've had their rights overridden, and so they want to be more confident that their preferences can be understood and respected. But we wanted to apply to everybody who might receive mental health care in a crisis situation. So I think there's another Mental Health Act slide, Johnny, is there?
Is it there, Tony?
Okay, yeah. So again, in Australia, a responsible clinician is responsible to take steps to find out if there is an advanced directive. So they need to look in the clinical records with the system we've got set up in Southern DHB. That's very easy. And there's a requirement to follow some process if the AD is to be overridden. So it's not a matter of saying, well, you're under the Mental Health Act, so we're just going to set that aside. And there needs to be reasons given for that. So there is this notion of a self-binding advanced directive, so-called Ulysses contract, where somebody might say, if I'm unwell, I want you to give me this treatment, because I know that when I become unwell, I'll say I don't want it, but I know now that I am well, that it will be helpful for me if I have it. And typically the person who's cited there is the person who's had a manic episode and knows that when they become manic, they become difficult to reason with, and they have an unrealistic idea of what's helpful for them. So that's what's called a Ulysses contract, where somebody makes a statement about they want to have this, if you like, coercive treatment in advance. It's probably worth also saying, though, that always the clinician has to make the decision at the time about what's the appropriate care. So even if somebody has said they want this treatment, if this happens, if it's not appropriate for some reason, then it shouldn't be provided, but the process needs to be followed, working with the person around it. Johnny, do you want to talk about the Maori?
So I'm not going to talk about the activation activity grant and the possible long-term HRC grants. I just like to mention that we've put in an ethics proposal to do a Maori-centred map, and we have Daniel and Matt and myself working on that, and hopefully we'll have the Kaumatua Mohi from Southland, and we've got a strong interest from a Kaitahu researcher, and so we'll hopefully we'll have a really strong team around this, and we'll do a similar process but different with Māori Tangata Whaiora and whānau and staff around what a Maori-centred map might look like. So that's pretty much it.
Can I speak about that briefly, Johnny?
Yeah, absolutely.
Just before I do, though, I'd like to acknowledge I've just been looking at the comments coming up, and I see that Heather Casey is here tonight. Welcome, Heather. And Heather's been a real champion for advanced directives in the southern region, and it's been a great pleasure to work with her on this. But really, I think that the thing that's made this project work in the southern DHB is Johnny's initiative and sponsorship, Heather's good links with the DHB management and support around it. If anybody's thinking about initiating an advanced directive project within their DHB, I would say the first things to do are to get your champions on board, consumer driven management support, get all that in place, and other things will kind of come in around that. I don't think we would have got through all the hiccups that we've got through without that very strong support. Really excited about the next stage, the Maori-centred development. From the beginning, we talked about that, but it wasn't something that we specifically factored into the original research. That hasn't been done internationally. And as you all know, in New Zealand, I think we do have some real expertise in looking at research that is meaningful for our tangata whenua or Indigenous population. So we're starting to come together really nicely. And as Johnny mentioned, the team that we've got coming in around that, and I'm really looking forward to that. I think that's going to be quite an exciting development. Really exciting. We do need funding, don't we, Johnny? But we're working on that. Yeah. So we could actually pause at this point and take questions. I don't see any more coming up. Okay. Somebody's mentioned advanced care plans. That's worth talking about. Yeah, Pauline Brennan, thanks, Pauline, for that question. I'll read it out. It sounds like advanced care plans. These are accessible in primary and secondary care via the whānau tahi care plans. They're electronic, maps accessible to primary health care. Well, let's just talk about maps and advanced care plans. One of the things we're going to be doing reasonably soon this year is presenting at an online conference with Health Quality Safety Commission, who you may be aware have done a lot of work around advanced care plans, mainly for end-of-life care. And so they've got now a very strong track record in that area. I've worked with some of the researchers doing that, Mirren Gott and Rosemary Frey at the University of Auckland in the past. So our view of that is that an advanced care plan of the type we're talking about has got some specific kind of differences to what's been done currently. To answer the question about are they available electronically and in primary care? Well, we're only working in Southern DHB at the moment. I don't think that's linked to the primary care information system, is it, Johnny? You would know.
No.
But we have had interest. We definitely have had interest from consumers about having their GP
Absolutely. Oh, no, sorry. No, yeah, you're quite right, Tony. So there has been quite a bit of interest for people around the emergency department and the GP. And in fact, some of the focus groups, people have said that they struggle to feel comfortable talking to the GP. And you can actually write a map, take it with you, and just hand it to the GP if you wanted to, if you feel that there's a power imbalance there. I believe that's possible. And yeah, sorry. So there is an interest from primary care. And I think it'd be really, I think one thing I haven't done is actually getting a lot more information into the GP practices, and perhaps that's something I could start doing.
Yeah. Okay, I'll just have a look and see if there's any more questions. have you considered closer collaboration with the South Island ACP program about using the ACP electronic process on HCS? Johnny, that's a...
So I wish Heather was here because she could answer that really well. So she's worked with around that, and we haven't the mental health advanced preference is slightly different to the advanced care plan, and they are similar, but they don't quite sit as one tool. That's my understanding. I think Heather would
we're hoping to get a bit of dialogue about that, aren't we, Johnny? At that Health Quality Safety
we're always interested in dialogue, absolutely, and it may be that somewhere we find a place for things that, you know, they can sit alongside each other as useful.
Wonderful. Thank you very much, gentlemen. You're full of passion. You can just see the excitement bouncing out the pair of you as you talk about how you work. Thank you. Yeah, just where you're trying to lead things. It's sounds like a work in action, but you've achieved a lot already, which is fantastic.
Yeah,
so, thank you.
Yeah, it's definitely achieved what I was hoping for, which was to increase the number. Be really good because, you know, 80 is a lot less than 1%. Be really good to get it up to 50% of people that use services having one.
Yeah. But you've got to start somewhere, you know. You start with planting the seed and then you grow it. And if you see the interest you're getting from other DHBs even this evening, that might take them back to then have a conversation and look at your website and your tools and then think, well, how can we grow this to suit our populations as well? So it's really fantastic. There you go. So Heather's just said, ACP is often slashed with end-of-life care, and this is a very difficult association for people who are wanting to be proactive about their care when in crisis.
Yeah.
And Paul,
but one of the things we might do sometime is to maybe write something up around ACPs and advanced directives, you know, similarities and differences. I think the reason we've kind of worked within our own team on this project is we had to get really clear about what consumers wanted in mental health, and we know that there may be some specific issues that apply in mental health that don't apply in general health care. So we really wanted to get clear about that. And also kind of get clear ourselves what we thought an advanced directive in mental health should look like. And I think we are much clearer about that now. And yes, in answer to Pauline, great to work side by side. Yeah, and I think that can happen. I think we're in a position now to know what we want as far as the mental health side of that equation is concerned. So.
And Jessica's asked, according to the HDC advanced care plans, have a set of rules around advanced directives, and MAPs do have a similar set of requirements to advanced directives.
According to the HDC advanced care plans, have a set of rules around advanced directives. I'm not quite sure what rules you're referring to. Jessica, do you know what they are, Johnny? Are they around capacity, that kind of thing?
I imagine that would be correct. And there's 5 clear rules that the HDC have around it. One of them is competence. So
to be reviewed, yeah.
So we've taken competence right out, and we've assuming, because competence is a legal definition and it sits outside of my scope and it sits out of the scope of most of us, so what we're assuming is that everybody who's done a MAP and it's been witnessed is competent. Yeah. And of course, the other ones are that it's been done without coercion, so it's been done of their own free will. Absolutely, really important. And that one of the things that we haven't talked about today is, does the advanced directive go out of date? Well, it doesn't actually go out of date, but circumstances change. And so a person like myself, I'm married now. In 6 months, I might be divorced, and it might be that the person that I want to be involved in my care is my wife. But in 6 months' time, if we're divorced, she might not be the person. So it's really important that it's relevant and the circumstances are up to date. And also, if you have something in a MAP and you might go into hospital, for example, and then something happens in the hospital, and you come out and you look at the MAP and think, well, actually, I would like to add this now and add this and change that. So it's really important to change that as the circumstances change and as your views change. But the map doesn't go out of date in the sense of an expiry date.
Okay, so Jessica's posted what the rules are around ACPs, and I think we've covered that in some of our publications, criteria, if you like. They're not rules as such, but yes, the person is assumed to be competent and free from coercion when they create the map, and are they appropriately informed?
Really important.
Yeah, I mean, that's been a large part of what Johnny's been doing with Jesse, going around the DHB and kind of making information available. But yeah, I mean, at the point of writing it out, the person needs to be informed. And does it apply to the present circumstances? Yes, that's right. So that's definitely an understanding of maps, that they have to apply to the present circumstances, and is it current? So as Johnny says, there's no expiry date, but if a map is very old or a person's circumstances have changed considerably, then it's like any other aspect of care. You know, you have to kind of look at what does the person want now and how can you best assess that. Just very quickly, Catherine's asked about the difference between RAP and MAP. They are different. I don't think we've got time to quite go into that at the moment, have we, Johnny?
Not really.
But they are different. That's the short answer.
They are. So the reps actually own. The reps owned by. It's a big long discussion there. But we do put the map inside of some people's plans, so their rep plans and things like that. There are comparisons, absolutely, but I think that this is we don't do rep plans really in the Southern DHB actually. There's a copyright on it. Marilyn Copeland's got a copyright on them, and so you have to actually do it her way. If you change it, you're breaching copyright.
Johnny, I think we have to wind up. It's 1 minute too. Okay. Happy to take people's questions through mobile health or whatever way you want to put them to us, but thanks for coming along, everybody. Do you want to close, Kathy?
Yeah, no, that's great. Thank you very much, John, to both of you. Fantastic webinar. People have really enjoyed it and appreciate your research, and just saying thank you for all that you've done. Very helpful presentation, interesting. And I just believe you're going to make your slides available afterwards, and Mobile Health will make the webinar available once we polish it up. And also thank you once again for all your enthusiasm this evening. It's been fantastic.